The suitability for endovascular repair has been a subject for debate for a long time, and it continues to be a subject for debate. I'm in favor of being strict with the instruction for use, the IFUs of the stent or the equipment we are using to treat those patients. This is a controversial topic, but the evidence is clear in the literature and from the real-life experience that when you stick to the instruction for use, you are on the safe side. In the majority of time, you end up with a better outcome. When we choose a treatment modality for the patient, that we should not choose the modality because it suits the operator or the interventionist. We should tailor whatever we are trying to do to the patient's needs.
There are many ongoing controversies. The NICE guidelines, of course, were published eventually after a lot of discussions and debates, and the ultimate guidelines probably make the compromise between mandating using surgery in pretty much all patients to giving some flexibility, giving some support to the MDT process in determining which patients undergo EVAR. One size does not fit all. So centers that were didactically going on to treat either with just surgery or either with endovascular or endovascular only approach, neither approach, in my opinion, is correct. And in fact, the evidence suggests we have to be much better at selecting patients. And this is the real controversial area, is which patients would benefit from which. Now, there is some data telling us clearly if the patient's fit, then open repair has distinct advantages. But sometimes there are other issues, the anatomy, the position of the aneurysm, previous surgery, which even in those sorts of patients might make life difficult, horseshoe kidneys. All these factors need to be taken into consideration. So what we need to be heading towards is really a much more patient-focused treatment algorithm.
The future research has many areas that should be focused on. We need to look at a refined patient selection for intervention. The sac size is an area that I think needs to be further studies and correlate that with the overall clinical picture. Patient selection is something that people need to focus more and need to develop the guidelines in a much clearer way. We need also to look at the durability issues in endovascular repair.
What we need now is more data and tell us where these fit into the algorithm of treating patients. I know in my own practice what I do and what I like to use, but we need some more evidence-based practice guidelines and studies that really confirm where we should be heading with these different technologies.